Right, and hello everyone. It's lovely to see all of you joining us today. I think we've got a really exciting time with some excellent speakers on a different kind of topic, and that's quality of life. Okay, so as we're all ready, I'm going to just share where we're at, and we can have a look at what quality of life is before we start. Oh, and now it's telling me I have security. Okay, so we're looking at real life gains and the importance of quality of life. But before we do that, let's just look at some of our etiquette of how we participate online. So please put your name and organization. You can click on your name in the participants panel to do this. And please, to avoid any background noise, could you mute your microphone if you don't speak, and also mute your phone so we don't hear it ringing. To help with your stable internet connection, it's best to close all your programs on your device. And most importantly, your comments and questions are always welcome, because that's what we're here to do, is share knowledge amongst each other. So we're looking forward to that. Just to let you know that there is English captioning available if you wish to use that. You can see that on the bottom there where it says closed caption. If you click that on, you can see the English captioning there. Okay, now you can always know there's going to be a Mentimeter. And so here we're going to go with our first Mentimeter. So that code should come up. Right, so there is the code you can put in, 4188-3752, or use the QR code. So if the QR code doesn't work, use the number 4188-3752. So are we ready for the first question coming up? Or maybe it's not coming up. There we go. What is quality of life? So that's an interesting thing. What is quality of life? And we've started with one person, hearing. All right, is this a challenge? Come on, think of one thing in your brain. Rest, joy, listening effortlessly. Great. Okay, anyone else on quality of life? I know there's more than 3 of you watching. Participating? Is it a challenge? What is quality of life to you? Ah, we're getting sailing. I like that, and that's it. Hobbies can do it. No worries, happiness. Yeah. Anyone else with great quality of life? No worries, hearing my family. Our family is really important. Connecting with them. Rest, relax. Yeah, I'm liking that. Being creative. Now we're going education. Drinking beer. That can really affect your quality of life. It's a good thing, I hope. Education. Where are we going? Peace of mind, time, health. Yeah, I think we really do have a lot of ideas of what quality of life can be. And as you can see, they're all very different. So it's really something that's internal for you and what affects you. And what my quality of life isn't exactly the same thing as the person sitting next to me. Okay, let's carry on, Julia. Okay, so now if we have a look at what quality of life is, the WHO gives a nice definition here, which I think can put it into some kind of context for us. And that is, it's an individual's perception of their position in life, the context of the culture and the value systems in which they live and in relation to their goals, expectations, standards, and concerns. So there are a lot of factors around there that can influence your quality of life. And I think it sits in this, it's the individual perception, which is exactly what we saw on the cloud for our question earlier. And I quite like this. We can see that quality of life is so many different things, and what one aspect might be more important to a person than another. So we can look at, is it your overall experience of life? What is the impact, material living conditions? I'm not sure, you know, Harlow's hierarchy of needs. Now at the top is also having devices, things like that. It's certainly not the same needs that it was 100 years ago. Maybe it affects your productive or your main activity. We saw there, people said education is part of their quality of life. We saw that in the cloud. Health, and I think we're here, health is one of our biggest concerns that we're looking at in CI world. Leisure and social interactions, economic and physical safety. Also, what governance and basic rights you have as a person in your culture and in your environment, and also natural and living environments. So there's so many factors, and maybe all of these circles aren't the same size for each person because some things affect you more than others. And that's why I think quality of life is such an interesting thing for us to look at and for us to measure. If we look at it more from like a healthcare perspective, we can see a few more things, like it's really how an ailment affects a patient on an individual level. And I saw in the cloud people were talking about hearing loss, that kind of thing. One of the things that also is to the degree to which you enjoy the important possibilities of your life, who one is, how one is connected to one's environment, and whether you achieve your personal goals, hopes, and aspirations. So I think it's something we should always think about when we are working with our patients. So we have another question, because now we've looked a bit what quality of life is and how it could impact on you. But I'm now going to ask Julia to share. So our code 41883752, or you can scan the code. So just try scanning the code, that's usually easier. Otherwise, if you have trouble with that, let's look at 41883752. Okay, so let's see what the question is. Yeah, in our world, why should we measure quality of life? Okay, we've got a patient coming in, we're very good at doing audiograms or an MRI or speech scores. Why should we measure quality of life in our package when someone comes in? All right, I think we're tested now for education, yeah, to show benefit, real benefit. Okay, people are thinking a bit more. Any ideas? Education, we've had that. Patient satisfaction, psychic health, psychology is important. To improve counseling, I do like that. Improving the hearing devices. Anyone else thinking? To assess improvement, we've had that, good. Okay, so what we're seeing here a lot is counseling, benefit, variations, health, economic, yeah, that's also something we can have a look at it. So I can see that there are a lot of things we can think about here that we could say, why do we measure it? Why do we measure it? Comparisons, variation, expectations. Yeah, I think we've got a good scope here. All right, Julia, let's carry on. Okay, I'm not really sure why it went back here. Okay, who is this? Okay, That's your question. Who is this? Okay, part of our team today, and that is something that shows a bit of quality of life for our presenters. And I know someone in the first cloud said hobbies. So here's a hobby. It's Javier Gavilan, and he is actually, besides a motorbike rider, a professor and chairman at the Department of Otolaryngology in La Paz University in Madrid in Spain. Right, so motorbiking is one of your things, Javier. I want you to tell us what quality of life actually means. Let's hear from you.
Thank you very much, Ilona. Thank you very much.
And everyone, it really is him.
I appreciate your words. And well, you know, I'm a professional biker and an amateur doctor. At least this is what I wanted to be. Anyway, I would like to thank, first of all, Ilona and the MED-EL team for giving me the chance to share with you these ideas about quality of life. We have been working on quality of life. I performed my first study on quality of life in head and neck oncology in 1997. This is 25 years ago. So we have been working quite a lot of time on this. And I'm going to make a very short introduction of the topic, and then we will go to the presentation of Luis, more focused on specific issues related to hearing, and then we will have the discussion. After the Mentimeter question here, there's a beer missing, but apart from that, this is a good quality of life. We all agree. The problem is that this is not the kind of quality of life we are going to discuss. And the kind of quality of life we're going to discuss today is dealing with the definition that Ilona mentioned already, which is the idea of knowing how someone has a perception of his or her position in life. And you have to be aware that this is in the context of the culture and value systems in which they live. So it's not the same here in Madrid that there where you're listening to this experts online meeting, or in another continent, or in another place of the world. And this is in relation to goals. So what we want and what we expect from life. What are the standards of our surrounding and our concerns? I know this is very easy to understand, but it is very difficult to define and to measure. So to summarize what quality of life means, we have to go to a previous definition also by Ilona, which is by the WHO in reality. It is the degree to which a person enjoys the important possibilities of life. So it goes something about enjoying. So quality of life depends on goals and priorities. What I want in life, what is most important for me in life, and as Ilona was also saying, what is important for me to take a motorbike ride may not be important at all for many others. So it depends on every single individual. It is obviously subjective. It is not something that we can define. 8 times 4 is 32. No, this is something that depends on every single person. It's extremely important. It changes with age. My quality of life today, my idea of quality of life today is not the same I had 30 years ago, and is not going to be the same I will have in 10 years of time. And it is, as I mentioned before, strongly influenced by social and cultural issues. The society in which you live, the culture you have, religion, social relationship, all these facts interact and define quality of life. To summarize, quality of life reflects the difference between what we have, which is the reality of our life, and what we would like to have. This is our expectations. We are a cat, but we would love to be a tiger. And if this is such a big difference between reality and expectations, your quality of life will probably not be the best, because you have to match. Quality of life is the matching of expectations and reality. Coming back to the field of medicine, quality of life was first mentioned in medicine in 1966 by Elkington. He wrote an editorial about medicine and quality of life. You have in this paper, it says a brief history of quality of life in medicine, and you can find all details about the evolution of quality of life. But this is 1966, and it took 31 years for quality of life to become a keyword in Medline. And this is what happened. If we move just 10 years ago, I'm not saying 30, I'm just saying 10 years ago, and you go to PubMed, you try to search in PubMed in 2012 about quality of life, you will find almost 60,000 papers about quality of life. 60,000 10 years ago. Today, nearly 500,000. And you see here how the articles of quality of life have been growing over the last few years. So this is an expanding topic. This is something that people more and more want to know about because it's important for our approach to the patients. If we focus on our specialty, otorhinolaryngology, head and neck surgery, I told you this at the beginning. I started to do studies on quality of life 25 years ago in the field of head and neck oncology. You're all aware that oncology treatments are very aggressive. And once we have cured the patient, we want the patient to be happy, to have a very good quality of life. And this is why quality of life started there. But then it spread fast, very quickly, over different areas of the specialty, namely cochlear implants. It's something that we will deal with today. Otology and neurotology, sinonasal diseases, general otolaryngology, all over the specialty and all over other specialties. I was telling you at the beginning that it's very easy to understand the idea of quality of life, but it is very difficult to measure. And to measure, we have multiple tools. But basically, we have two groups of tools, and this will be developed by Luis in a few minutes. These two groups of tools are generic tools. They measure an overall idea of quality of life, and disease-specific tools focus on acoustic tumors, cancer, hearing problems, cochlear implants, and both groups, they have a lot of different questionnaires. And just to mention something, these questionnaires should be adapted to the social and cultural situation of every doctor doing a study. So the GBI, to be valid in Spain, must be evaluated, it must be officialized in Spanish and make it be true as a measure of quality of life. So it's not just the generic or the disease-specific tool, but adapted to every single situation. And I will not say more because I will leave time for this. I want to leave time for the discussion, but I just want to let you know what we have learned in these 25 years of studying quality of life. And I will just focus on three different topics. One, success and failure are different for patients and doctors. A very clear example we discovered was doing a study of quality of life after removal of acoustic tumors. For the surgeon, the most important thing for removal of an acoustic tumor is to preserve the facial nerve. For the patient, this is not the most important thing. There are more important things than just preserving the facial nerve. And therefore, we realize that patients and doctors have different views of the same problem. This is from quality of life studies. Number two, information and support are crucial in all fields of medicine. And the information obtained in quality of life studies is wonderful to provide better counseling to our patients. The things we learn enable us to match for the patient expectations with reality by counseling them about their main problems after a treatment or operation or the evolution of a disease. And finally, quality of life studies are very useful, are cost effective, and help defining treatment goals and expectations. Again, we want to match expectations with reality. And we'll discuss this over this afternoon. I wish you all a great quality of life. But remember, to have a good quality of life, you cannot have just a small part of the picture. You need the full picture. Thank you very much for your attention.
Not sure everyone liked that last picture. What's coming up behind you? I hope that's not in any of my quality of life questionnaires, that's for sure. Okay, so we have the motorcyclist done. Thank you very much, Javier. But now we're going to show about how quality of life and your hobbies and things that make you happy, because that's what I asked for, pictures of quality of life, what the next one is. So we've had a motorcyclist, and now we actually going to have someone who really exercises rather than just sits on something with an engine. And so there we have Luis Lasaletta. Right, Luis, you know, and that's why you're nice and fit and, you know, probably have a greater lifespan than Javier on his motorbike, but I'm not biased or anything like that. Luis, it's a pleasure to have you here. Luis is the Associate Professor at the Universidad Autónoma de Madrid, and he's also head of Otology section at La Paz University in Madrid as well. And he's going to tell us a little bit more about your quality of life outcomes. Am I correct, Luis?
Yeah, that's right.
Good. Okay.
Thank you.
Then let's see.
Thank you very much, Ilona. Well, I have to say I'm a little bit scared still from Javier's last slide. Well, so good afternoon, everybody. I will carry on speaking about the importance of quality of life, but now specifically about quality of life outcomes following hearing implants. So in this slide, you can see what most people would think about this topic. So it looks quite straightforward. A patient with hearing loss undergoes surgery, he or she receives a hearing implant, there is an improvement in hearing, and this leads to an improvement in quality of life. So it's that simple, right? Well, definitely not. It's not that simple. Why? Because there are many complex factors, complex issues that affect this relationship. We have learned about these factors in different studies during the last years, and I will like to show you just some examples from 3 studies. I will start with this recent study from the hearing group. In this study, we included 110 patients with a CI, 41 with a bone bridge, and 18 with a sound bridge. As you can see here, participating sites included implant centers all over the world, all of them from the hearing group. And in this study, as Javier was explaining, we used both generic quality of life and disease-specific quality of life measures. So we used the HUE 2 and 3, and as disease-specific tools, the SSQ-12 and the Nijmegen cochlear implant questionnaire. So the results of this first study showed a significant improvement of both generic and hearing-specific quality of life tools within the first year of hearing implant use. Here you can see the improvement of the SSQ-12 scores from preoperatively to 6 months and 12 months, and this happened with all the questionnaires. But I'd like to show you an interesting finding of this study you can see here. So using generic quality of life measures, in this case the HUE 3, the changes with this generic quality of life measure was stronger when we evaluated the CI group when we compared it with the bone bridge and sound bridge groups. So this suggests that the change in quality of life in some way depends on the hearing implant, and this also depends on the type of hearing loss. So it appears to be bigger stronger in patients with profound hearing loss when compared to patients that still have some residual hearing, and that's why they undergo a bone bridge or a sound bridge. Let's move to the second example. This study led by Miriam Calvino. In this study, we compared 113 patients undergoing a CI versus 50 patients that received a CI but were also wearing a hearing aid. So we found better speech results, as you can expect, in the bimodal group when compared to the CI only group. But interestingly, quality of life measured with the SSQ-12 and quality of sound measured with the HISCI were similar in both groups. That is, adding a hearing aid to the CI improved hearing, but not quality of life or quality of sound outcomes. Why? Well, maybe due to different expectations. We can think that maybe CI-only users are usually satisfied with their CI because they have no useful hearing in the contralateral hearing, in their contralateral ear, and in some way, CI allows them to access the hearing world. In contrast, bimodal users usually have better preoperative contralateral hearing and therefore may also have higher expectations for the electrical stimulation with the CI. So this finding of this particular study emphasizes the importance of counseling. So we must ensure that CI recipients have realistic expectations about life and hearing with a CI. And in this third and last study, led by Isabel Sanchez, we compared 18 implanted patients with Meniere disease with a matched control group of 18 CI patients, but without Meniere disease. Quality of life was assessed with the Nijmegen Cochlear Implant Questionnaire, the GBI, the SSQ-12, and the HISCI. So we found a significant improvement both in hearing outcomes, in quality of life, and quality of sound in both groups, in the Meniere and non-Meniere groups. But interestingly, quality of life outcomes were clearly worse in a particular subset of patients, those patients who underwent simultaneous CI and labyrinthectomy, when we compared those patients with the rest of the Meniere disease group. These patients had very good hearing results, but bad subjective perception of their quality of life following surgery. Why? Well, this could be explained by both the impact of bilateral vestibular dysfunction. Most of these patients have bilateral Meniere disease, but not all of them. But maybe more due to the loss of residual hearing, as these patients with Meniere disease may undergo a CI with relatively higher levels of residual hearing when compared to the usual CI candidates. That could be an explanation. So if we come back to the first slide, apart from the improvement in hearing, there are many other factors, some of them really complex, which may impact quality of life following a hearing implant. Among these factors, we have learned about cultural demographic differences, as Javier said, the type of implant, the type of hearing loss, fundamental expectations and counseling, contralateral hearing, how we assess quality of life with generic or disease-specific questionnaires, and we have seen etiology of hearing loss in some particular subset of patients. So this is all. I'm sure we will discuss some of these factors during the next minutes. Thank you very much for your attention.
Thank you very much, Luis. I think you've given us a lot of ideas there, or maybe scared us a little bit into seeing what happens that's going on. Okay, so I really liked this quote: "The quality of life is more important than life itself." I don't know if that has some a meaning to other people, but I really liked it, and maybe because the quote also is on an African background, which is really special for me, and that's part of my quality of life is when I go and look at animals. But now we're going to talk about the next thing, and that is our tradition of having the group photo. So I want you to make sure you've got your lipstick on. Javier, you've got your lipstick on?
Sure.
You've combed your hair. Can everyone put their cameras on? That would be really great, so that we can all get ready. I'm looking, yeah, we've got some on there. Right. Julia, are we ready for our waving? So everyone's had time to put their lipstick on and do the wave. And I guess we're done now. I think we're all beautiful. So thank you very much indeed. Now it's time for questions, because that's important. And I haven't seen anyone in the chat. So I think maybe that Cobra's really killed everyone's idea. Javier? No, he's not too worried. But we have wanted to have quite a discussion. So maybe Luis and Javier, if you can be there.
Yep, we are there.
There we go. All right. So we talked about a lot of things in both of your presentations to see how things work. And I think one of the key things that would interest me is, what are people's expectations versus what they actually got? How do you measure that? Do they tell you that? Is there a difference from what they expected before to what they had afterwards in terms of quality of life?
Well, I think this is one of the main issues. They don't tell you exactly what they want, but you find from a quality of life study, you find that you thought it was very important, the facial nerve or the acoustic tumor removal, and then the patients tell you that for them the major concern is losing the residual hearing on that ear. So they don't tell, they just rank their importance items, and then you learn from this ranking where you have to put more information in the next patient.
Mm-hmm. Mm-hmm. And how would you see that, Luis?
Well, I think you have to ask the patients. Most of the patients won't tell you directly. We have to think that getting a hearing implant is a surgery intended mainly to improve quality of life. I mean, to improve hearing and to improve quality of life. There are other surgeries where the patient can lose a little bit of quality of life, and it's fine. But here, it's just for that. So some of the patients will just complain about, let's say, stupid things, but some of them won't tell you if you don't ask them. So I think you have to, of course, ask them, but you have to use specific tools to know exactly what's going on.
Yeah, I think that's an important thing. Now we have a question. Agnieszka, I think you've got your hand on. Would you like to ask us? Well, yes. It looks like you're having quality of life there.
From the jogging. I am a healthcare professional working in oncology, but I am also a CI user since December 2021. And that's why I start to learn so much about it. And I would like to say something about this expectation, because of course in life you always want to achieve more. And you also have a lot of webinar concerning how the implants sound. And actually, in my opinion, we should emphasize that the patient's representative and some patients organization could help a lot, because there is many things that only patients can solve. For instance, in my example, I had issue with the quality of the sound. If I hear with the microphone, the sound is like a Mickey Mouse, like people talk, let's say, without any testosterone, like that. And if I use the telecoil, then I hear some kind of whispers, like everybody are whispering. And I was wondering why is that? And actually, the patient helped me with some my loop device, my telecoil. So I think we should go in this direction. And actually, in oncology, there is a lot of patient organization. They support each other. They give a lot of hints because actually, as a medical healthcare providers, we can support them, but we don't have time to go to spend so much time with them. We can support them, and actually this is, in my opinion, their role to support each other. And in one slide you show that first quality of life was assessed in oncology and then here in audiology. So I think also with the patient, perhaps we could look how it looks like in oncology and do the same here with the patient with hearing loss. Just such a comment. Thank you, and have a nice day.
Agnieszka, so first of all, we envy you being outside. It looks lovely. And also thank you very much for your input, because I think this is a little bit what both of you talked about, that what your expectation is as a surgeon or an audiologist or as a speech language therapist is completely different to what the individual perceives or what they want. And so I think your idea of including other patients is always a good thing, so that they kind of know, if they've already had a hearing implant, what it feels like for them, so that they can help you with those expectations that we get. And I think that is one of our questions we talked about, Javier and Luis, about what is the difference between what the patient feels versus what you see in the audio booth. How would you describe that? Because we see in literature that it doesn't always correlate.
Yes, I think Agnieszka just told us a couple of things that are completely true. The more I hear about expectations, the more I think that we have to improve counseling. I think that's our goal. So maybe patients need more patients, they need more information, but us, I think as doctors, we have to provide them enough information. And I think when dealing with hearing implants, there are mainly two things that we have to tell them. First, mainly speaking about CIs, is that they may not get natural hearing, so we have to adjust expectations from the beginning. We don't know exactly which point they will reach, but they at least it should be okay if they have normal conversations, but with not always natural hearing. That's the first thing. And the second is that after surgery, the second process starts, and that depends on them too. So their attitude, how they deal with the fitting, with the rehabilitation, it's really crucial, and they really have to know that. But anyway, apart from these two main points, I think it's improve our counseling is key.
Would you add on something there, Javier?
I think well, I mentioned that in my presentation. I think counseling is the thing we've learned more from the quality of life studies. I will put you an example, a very clear example from the field of oncology, which is not our topic, but this reflects exactly what happens in otology, in hearing problems. When you tell a patient that he or she has to undergo a total laryngectomy, what is the first thing the patient say? I don't want to lose my voice. Then you do the laryngectomy, you do the quality of life study, and you know what's the problem of the patient? It's not voice, because voice, they communicate with artificial methods, they get communication, but they have a stoma. And this stoma makes them different when they go to a restaurant, when they go to the beach, when they go to the theater. And the problem is the stoma. We learned that from quality of life studies. Even the patients don't want to lose their voice, but the problem for them is the stoma. Then you go and use this information for counseling. And you tell the patient, you will speak, you will get better, you will be able to do normal life. But this is going to be a problem for you. So you have to know that this will be an issue in your future life. So at the beginning, you don't know what you are going to get. The quality of life studies, they always astonish me because I always get results I was not expecting to get. And this is good for counseling.
Yeah, I think Christian here has just put in a comment. So Christian, I'm just going to read it out for everyone. Critical to understand the expectations of the clients, which we kind of looked at in our first thing. Physicians tend to focus too much on the medical outcomes, so that's hearing improvement, versus the more complex issue of quality of life. But training and discovering patient expectations is a tricky and complex area, and he pulls out things like parents have a different idea, children, maybe if they're adult, older children maybe, and also kids who got it very young and they grow up and then they're teenagers. There's a whole different culture there in there called teenagerism. There's a lot of other peer pressure, also what you said there, Christian, all different walks of life. So we've talked about that as well, and that you agree that counseling is a high priority. So I think that backs us up. But now when we look at the counseling and stuff, you assess patients, you get their quality of life measures. So do you take like the SSQ and say, okay, we've got the value and then each of the subscales and it's a score and that's great? Or do you look into what they are saying? And I'm not talking necessarily from a study perspective because studies like numbers, but if you look at, do you look at the questionnaires? Do you or the audiologists or the speech language therapists look at those and say, oh, this is what they're saying, and then how do I use that? Is that part of a process that you would do? Is it important?
It is. I mean, I think it's crucial. It's like when you do a questionnaire after this experts online session. You get a ranking, you get figures on one side, and then you put always at the end of the questionnaire comments. And you read the comments and you get an overall impression from your statistics study of the overall questionnaire, overall study, but you focus on the comments made by the patients, and you do that in every single quality of life study, I think.
That's right. Well, you know, Ilona, we have the luck to work with Miriam Calvino at La Paz Hospital. So she's always giving all kind of questionnaires to all patients coming to the waiting room, and that's how we perform these quality of life studies. So they are useful for studies, as you said, but then when we look at them, I think it's useful to identify specific problems. I mean, when you just see like a surprise, so a patient that should have like and has in fact good hearing results scores badly some of the questionnaires. So you have to check, maybe it's they didn't understand the question, that's something that sometimes happens. But when you find that the patient is not satisfied, it's useful to identify problems. So I think that's one of the things you can get from these questionnaires. You speak to the patient and then you try to find if this problem is related just to adaptation or expectations, or there might be a real problem related to feeding or rehabilitation or whatever. So I think from a clinical point of view, these questionnaires are also useful.
Okay, so when you've looked at it, because I know you've done a lot of studies and whatever, but when you've looked at the contents of what the answers are there any themes that are coming out? You know, do a lot of them have similar issues with their quality of life, or is it just very diverse?
Well, in the beginning, we tried to add open questions to the questionnaires, but the problem is that it's great to know about the patients, but it's not very useful to work as a daily basis. So anyway, you can see that most of the patients have the same problems. I mean, they have the same complaints about maybe the days of feeding or a particular audio processor or a particular situation. So you can find that from the questionnaires too, but mainly they are structured questions. So you can get just numbers, a score. And as I said before, it's mainly to see if the score is lower than you expected to look at a particular situation.
Okay. And
there is,
so,
Ilona,
yeah.
there is something we haven't mentioned, and I think Agnieszka pointed it a little bit. Quality of life is not a picture, it's a movie. And the patient that may be very happy today after the cochlear implant because we adjust his expectations to the reality, 1 year, 2 years, 5 years from now, may not be as happy, because as humans, we always want more. And the moment you get used to what you have, you forget what you had. Your expectations come from here to here, and next morning will be here, the next day will be there. So we will always go up. So you have to be able to adjust every single patient to the new situation and try to improve their perception of the reality, because you cannot change what they are getting. They got what they got, and unless you do a new cochlear implant, this is what he must or she must have, and it's dynamic.
Okay, Agnieszka, I can see you. Again, would you like to comment on that? And now we can see her nice background again. Okay, you're off mute, so if you can't put on the camera, it's all right. Do you want to say something? Okay, Agnieszka, while you sort that out, let's go back to the chat. We've got Daisy here, and she says, do you use any quality of life tool as part of the assessment protocol to make a recommendation if the patient is a candidate or not for a hearing implant? So that would be part of your candidacy assessment. I guess that's what you're asking, Daisy.
No, I don't think so. I mean, it's really important to have this tool scored before CI, so you can compare the situation after that, but not to assess candidacy. I think candidacy, you have to deal with, of course, the usual hearing and imaging things, but it's sitting with the patient, adjusting expectations, and being sure that he or she will be part of the process. I think we are not using quality of life measures just to assess candidacy.
We use psychological evaluation. I mean, you try to discard patients that are not on the idea of a cochlear implant, for instance. But I think quality of life studies they may compare before and after, but I think, as was mentioned, that for indications, you go to the figures and you go to the personal situation of the patient, but it's not a problem of quality of life. I think quality of life comes later. Based on their expectations of what might be coming their way. Exactly. Right. So I know, Madrid, you've done a lot of stuff, and I know Miriam as well. What have you learned as a professional from, because I think you were really one of the first adopters of using quality of life questionnaires. It's really immersed in your practice. What have you learned from it? Well, I mentioned that. I learned that patients don't think like I do. It shouldn't be like this. I mean, I'm the doctor, and this is the problem. You are not the doctor. You're the doctor, but patients want something different. And the good part of quality of life studies is that you learn what patients want. And you'd agree with that, Luis?
Absolutely, absolutely. But here again comes what Javier was saying about the movie and not the picture. After years dealing with these patients, you know what normally happens. So it's all emotion and tears, the first fitting or the first two fittings, and then the patient comes 1 year later. I went to the concert and I don't feel to hear Mussorgsky as I did before. So you also have to adapt. I mean, that's real life, and you have to take that seriously too. So what you learn with these studies, that you have to be there before, during, and after. Try to be with the patient the best you can. but I think it's also useful to counsel all other patients with what you learn from these situations.
Yeah, so that is also learning how it impacts on your other thing. Now, it's interesting because I know, Javier, you said, I'm a doctor, but I'm not a doctor, but I'm a doctor, right? And we know there have been changes in people's attitude to medicine. So I know, like, for my father, the doctor is God, right? So what the doctor says is whatever anyone else says, he doesn't worry. It's the doctor. But younger and that's more like a medical centered thing. And the younger people don't see their healthcare as a medical centered process. It's more a well-being, more informed. They are more likely to look at second opinions or question you. How would you work with those people's quality of life when you know that the older person, and I know it's a generalization, that the older person says, I bow down to you because you're the doctor? How do you manage going through their quality of life? Because they might not actually say what's really wrong with them because you are the doctor. Is there a difference in age, say?
Well, I think there's a difference in age. The problem is that now we are the older. Well, actually, not Luis, but me. So I now understand, but 25 years ago, I was saying stupid things. Come on, patients must do that. And that was what they were saying. They were telling us, the older guys, they didn't accept the idea of asking patients. Patients should do what you want them to do. But we were trained, my generation, and Luis even more, we were trained on accepting the idea of what patients want. I mean, the idea of, because you say doctor are God. When I studied, it was not like that. I mean, it was doctors, then God, and then the others. So they were even more. So right now, we all accept that we are just a part of a team, and the patient is the center of this team working, and we have to provide the best attention. And for that, we need the patient's opinion. Even if they are not very smart, they don't have a career, professional studies, university, but they know what they want for their life. And we need to bring them what they want for their life.
Yeah, and I think that's really important, how you put the patient as the key. And I think that's probably the best practice that we can do. Okay,
that's
now
right.
I'm going to,
that also emphasizes the importance of having these teamwork studies, because quality of life for my parents, for my generation, for my daughters is completely different. And as we saw in the first hearing group study, quality of life of people from Sao Paulo, from Poland, from Arkansas may be absolutely different too. So it's really important to have this big group of patients with different ages and different locations to have the real picture of the quality of life.
Good. So now I'm going to turn it around a little bit, because now you've talked about teamwork. So you've used disease-specific. Now I'm going to ask you the hard question, right? Because you said, oh, Javier, you said, oh, my God, it's difficult to measure, right?
Always.
So, so you're in a clinic, okay, and a clinic is like, it's a factory, in and out, because you're seeing so many people, time or whatever. If I had to choose one, would it be disease-specific or generic? And which questionnaire?
Well, this is such an easy question that I will let Luis answer.
No, you're going to both answer now, Javier, but I'll let Luis go first.
I think that it's not so a problem of time. I mean, if you have time for one, you might have time for two. But if I had to choose, I would really choose the disease-specific better. If you can get the combination of both, it would really be better. And about the specific tool, maybe the Nijmegen cochlear implant questionnaire, even being so long, it's 60 questions, so it takes really time. But I think that the information you get, it's the best for disease specific. I also like the HISCI, so the combination of the HISCI and the Nijmegen would be great. But that depends, especially on what if we are talking about CIs or other hearing implants, because here the contralateral hearing really is important to consider.
Well, I think,
Javier?
yeah, Luis is the expert on the questionnaires, but I agree with him. I mean, I think the question, Ilona, is like who you love more, dad or mom. So
no favorite.
I cannot answer, but if I have to answer, I think overall quality of life is beautiful, but we are working on cochlear implants or hearing problems or cancer, and then we need a disease specific telling us what's going on that process. And for that process, we need a disease specific.
Yeah. And then I guess if I think about it, maybe with the patients, they're feeling, and if things aren't really going well, then it's also good to refer them on to either a social worker or a psychologist where they can look at maybe a bigger picture. Would that be one of your scopes to help to refer on if someone isn't really coping?
I think if the process is well done, you shouldn't have that problem. So sometimes you have a patient which is not satisfied. Most of the times, if the indication was okay, it's a problem of the patient. And I mean, as doctors, we should know how to deal with that. We sometimes find a specific problem that maybe can get harder. And I have to tell you that in these cases, sometimes when it gets you to the limit, what I would say is, okay, I'll take the implant out. I will go for surgery next week and I will remove the implant. And at that time, the patient, well, maybe I'm not so bad. Maybe we can try. And so I mean, if the indications are good, surgery is well done, and the feeding and the rehab are okay, it's really unusual to find patients with really big problems in which you need an additional professional.
Okay, well, that's good information. I think that's valuable. Now, we talked about a clinic being a factory, you know, in and out and in and out. So how do you get your patients? How do you manage getting them to complete the questionnaire? Because you as a surgeon have only a certain amount of time. The audiologist only has a certain amount of time. So do they sit with the audiologist and do it? How are you managing this within your practice?
Well, I just mentioned Miriam. We have the luck to work with her for a long time. So it's not her directly filling the questionnaires with the patients, but normally the patient goes with a relative or someone, and she can train the relative to help the patient. And the best place to do it is the waiting room. Normally, the waiting room for the fittings or the waiting room just for the normal office is fine. Sometimes we have to send the questionnaires by mail, but mostly they are done on the waiting room, so we can get them after that.
Yeah, and I think that's a good idea. It seems to me very time efficient from a professional point of view. I mean, we all know, sorry, doctors, but when you go and wait for a doctor, you wait. So,
then you fill the questionnaire.
So we know that actually that's not a bad time to get people to do it. And I think that's really, really valuable. Just one last thing. You've got a great patient and they come in suddenly and they say, my life is worse now. It's really bad. How do you manage that? They've been your star patient, great quality of life. What's the first thing you'd look at if they came and said, oh, my life's really worse now? Okay,
I think you should talk to the patient and try to find why his life is so miserable after the operation. But in my opinion, Ilona, the only reason for this is lack of previous information. The main reason for medical problems, medical litigation and medical and patients not being happy is because of lack of information. And with quality of life studies, you know what to tell the patient about the expectations. Patients feel miserable after something if they were not thinking that this could happen. And if they were not thinking that this could happen, it's because you as a doctor didn't tell him or her that this could happen. So I don't remember any patient saying, this is horrible, I want to remove, because as Luis mentioned before, when you say, okay, you're scheduled for tomorrow and we'll remove, they always say, no, I'm not that bad. So if you give information beforehand and you accept, because I mean, they can also feel miserable because of complications of surgery, of a bad result, of a real objective bad result. But even there, if you have a good communication with the patient and the patient knows that the problems may happen and medicine has a very low number of complications, but they exist and statistics are cruel and they are there. If you accept your responsibility and try to explain the patient and approach the patient, then problems, well, I haven't had a very serious problem in my life. And I think the main reason is that you have to talk to the patient.
You know, Javier, I think what you've done is you've created a circle in this discussion. And that's really going back to the beginning and about expectations. And I think, you know, I think that's a really nice way to end our discussion, saying, in the end, it's so important for us to counsel. And I think it's been a pleasure to have two world experts on quality of life here. And it's always a pleasure working with you. And I hope everyone who here has enjoyed it, and each of you have gone away with some kind of learning or something that you would like to do in your practice. So I want to say thanks, both of you. It's been a real pleasure. Really.
Thank you very much.
Thank you very much, Ilona.
Thank you.
Okay, so then we carry on. One last thing. And that is our next Experts Online. And I think this is going to be fun. Okay, 10 things I wish I had known as a young cochlear implant surgeon. And Javier, I think you already talked about one of them, and that was your expectations of being a doctor. So everyone, I'd like you to join us on the 6th of July at 3 o'clock, usual time, usual space, and we look forward to seeing you then. So I wish everyone a good day, and thanks and bye.